Welcome to Ask Dr. Geier Live. I'm so excited because I've been inside most of the day studying for my anti-aging and regenerative medicine boards later this spring. This is what I've decided to kind of do on Friday mornings because our office isn't open, and it is absolutely beautiful. I know I say this all the time about, hey, come see me in Charleston, South Carolina. You can see me as a patient because it is one of the most amazing places you'll ever be. It is 66 degrees, the bluest sky you'll ever see, and not a cloud in it. So when I came out of my office building where I was studying, I saw that and it put me in a great mood. Wherever you are, wherever you're watching, hope you're making today your masterpiece. That's right, it is Ask Dr. Geier Friday, as we always do. Jamie, it's good to see you. You're very welcome. I very much appreciate that you like the videos. I do my best. I do a live stream Tuesday, Thursday afternoons, 5 p.m. Eastern. I do this noon Eastern. I used to do a That's Gotta Hurt, which I've talked about bringing back, which is where I talk about pro and college athletes that get hurt and what those injuries are and potentially what that means for their teams and complications and recoveries and all that kind of thing. I may bring that back as a once a week show. It was just too much work to do basically every night, and there just weren't enough injuries to talk about, but that may be coming back. But the other thing is I'm trying to get better about some of the recorded videos that are not live. I've been doing my Better Than Ever dailies now. Make sure you subscribe to that podcast as well. Those are 35 to 60 second health tips, health studies that I also use for the 2 TV stations that I work for as their medical expert. If you ever wondered why I'm in suits for those, that's why. Those are for local TV here, but I also put them on YouTube. But I am also starting a weekly, it'll start next Friday, a weekly recorded Ask Dr. Geier video, like what I do here, but it'll be a question that probably that I got by somebody emailing me or something like that. And I will answer that in a 2 to 4 minute video. And as I've been doing now for a couple months, on Mondays, I also release a modern medicine video, which is a discussion of things like peptides, like we've done BPC 157 and thymosin beta 4, and I'll do one on mod-SC and things like hyperbaric oxygen and whole body vibration and things like that. So you can learn some of the things that are currently out there if you're in the functional and integrative medicine world. They will be out there if you're a biohacker and look for these types of things. I don't know when they'll make their way into traditional medicine, probably the next 10 to 20 years, which is really, really sad. But check those out on Mondays. Very, very excited to be here. I shouldn't tap that. I have a standing desk in front of me. You can't see it on this video, but right here. And people have told me that when I used to hit my papers on it, it would make it like a rumble sound and it would drive them crazy. Anyway, if you have orthopedic questions, sports and exercise injury questions, definitely this is your time to ask them. I stay as long as there's questions and then I leave because I don't need to do it. But I will stay as long as there are questions. Always remember, this is not meant for medical advice. I haven't seen you, haven't examined you, looked at x-rays, MRIs, any of that. So this is just meant for general information and educational purposes only, so that you can then go talk to your doctor, go talk to your orthopedic surgeon, say, hey, what about this treatment? What about that treatment? Why are you telling me it would be 6 months recovery? I've heard people say it's 9 to 12 months recovery, something like that. I mean, I'm not here to create trouble with your doctors or your orthopedic surgeons. I get a lot of this because I explain this in English better than just about any orthopedic surgeon does. I've learned that over the years with my huge volume of second opinion patients. But having said that, this is your chance to ask questions. I do it once a week. I don't do it in response to comments on YouTube or Facebook. I don't do it in response to anything on Twitter. I don't do it in response to emails I get. I just don't. I don't have time with everything else I do, including a full-time practice. I do it once a week, 12 p.m. Eastern time. So if you can't be here, if you're watching this recorded, and I know a lot of people watch these videos once they're up live or once after the fact on YouTube, but they are, if you want to ask a question, this is the time to do it. And I know it may not be an ideal time for people, but I get people, as Jamie here will tell you, I get people all the time that tell me it's 1 or 2 a.m. their time, and they're here to ask their questions. So, if it's 9 a.m. your time and you're at work, one Friday, I bet you can find time to do it, for what it's worth. All right, Jamie asks, if it still hurts in your shoulder, they're killing me now, go back April 21st for the shot. Jamie, remind me, I knew it was a shoulder problem. I can't get this off the screen. It was a clavicle problem, if I remember correctly. I'm not, again, and this may be tricky because I don't know exactly what the diagnosis is. So if it's something different, tell me. Cortisone shots typically aren't that helpful for clavicle type injuries. In theory, if the pain is at the AC joint, which is, you follow, I can't really get my scrub sleeve all that way over there, but if you could get it all the way to the end of your collarbone where it meets up with the tip of your shoulder blade, that's your AC joint. Sometimes a cortisone shot into that joint can be helpful. And sometimes that one shot is all you need. Sometimes, though, it wears off like cortisone does in every joint and you end up needing a surgery. But a cortisone shot into the AC joint can be great at telling you that's the source of the pain. One problem, and let me show you this. I should have gotten these ready, but I didn't. So the AC joint is, clavicle, collarbone, it forms the tip of the shoulder, the acromion, that small joint right there on top of your shoulder is your AC joint. The nice thing about a cortisone injection into that, or even a lidocaine injection into that, is that if the patient's pain goes away, that's the source of symptoms. AC joint pain is remarkably hard to diagnosed because it sort of looks like all different kinds of other problems. And so, yes, typically pain reaching across the body, but that isn't always perfect because other things can do that. But an injection into that can be helpful. Sometimes curative, most of the time not so much for what that's worth. Fractured both of your shoulders. Yeah, it really depends. With fractures, assuming that they healed, that's a whole other discussion. But if assuming the fracture's healed, things you'd look about, and it depends on what parts of the bones are injured. But arthritic changes, if it's the humeral head, proximal humerus, that kind of thing, or the glenoid, the socket. Collarbone typically doesn't lead to much in the way of arthritis. The problem with collarbone fractures is even if they heal, a lot of times there's enough space there that it may heal in a really awkward position, or it doesn't heal at all, and that can be a tricky problem. So that's why I think I've talked about this before, there's so much more of a trend to fix collarbone surgeries, clavicle surgeries on the front end rather than just a sling for 3 weeks or 6 weeks or things like that. So hopefully that answers your question. I'll go back through these in a second and see if I missed something. PCL avulsion fracture surgery, February 22nd. So I've said this before, when people recover fully really has nothing to do with the amount of time. That's just sort of an average, but everybody's different. So the PCL is the all right, front of the knee, looking at the back of the knee, it's the ligament, big, thick cruciate ligament behind the ACL in the back of the knee. And typically when you avulse it, usually you avulse the bone on the tibia side. I suppose it's possible on the femur, but it's usually the tibia. And a lot of times you can do a surgery where you fix it with a screw, and that does really well, and typically is faster recovery than an entire PCL reconstruction. So if you were going to say that, maybe 3 to 6 months instead of 6 to 9 months. But again, it's based on when you get your motion back. In the case of the PCL, when you get your quad strength back. Quad strength, critically important for a PCL recovery. Full ability to walk on it without pain, then running and doing sport-specific activities. So again, with PCLs, reconstructions, my experience, usually 6 to 9 months, sometimes longer for a high-level elite athlete, pro athlete, maybe 3 to 6 months if it's a true just put a screw in it for an avulsion fracture. Let's see. Oh, sorry about that. Full ACL tear, bone bruise, ACL. I don't know that I really understand that question. If you can explain that, but shorter so it's not real long, I will try to answer that. Something about ACL rehab. Happy to answer the question. I don't understand that one. Manipulation under anesthesia to loosen a knee that can't break. Manipulation under anesthesia would be, and it's good to see you, Brittany. So what, I forgot the numbers. 100 degrees of flexion, 3 to 4 months after ACL repair. So if you're looking at the knee from the side, that's full extension, or 0 degrees of flexion. 100 degrees of flexion would be about that much. Normally the knee goes to about 130, which is about that month. Some people can get to maybe 140, but anyway, that would be about 100 degrees. Manipulation under anesthesia typically is done for knee stiffness, and what that means is you go to surgery or a procedure where they make you really sleepy so you don't remember it, and they just forcibly push on it to try to break up scar tissue. Typically works much better for shoulders than it works for knees, and typically done for knee replacement surgery, which have higher rates of knees getting stiff after surgery, than it's done for ACL. Couple things, Mike. I'd be very concerned about a manipulation under anesthesia after an ACL because I would want to make sure I didn't tear the graft in that forceful manipulation. So I personally probably wouldn't do that. I would go in and scope the knee and clean out scar tissue. But also that typically needs to be done somewhere around 6 weeks after surgery, not 3 or 4 months after surgery, for what that's worth. You may get different opinions, but manipulation under anesthesia at 3 to 4 months, I cannot imagine is going to have much of a benefit. I don't think they'll gain much range of motion. Hope I'm wrong. I'd love to be wrong. Where are we here? I'm still not understanding this question. ACL rehab, ACL only with, I think what the question is, and I apologize, Gugu, if this is the question, is somebody tears their ACL, should you just rehab it and not have surgery, or do surgery and have rehab? Especially because I saw the word son, so I'm assuming this is teenager, young 20, something like that. Non-operative treatment for an ACL injury does pretty badly without surgery. There may be some people you get into your 50s, 60s where you're not terribly active, not such a big deal, but even that is a little controversial because the problem with a torn ACL is your knee's unstable. Basically the tibia can shift out from under the femur with landing from a jump. Running, planting your foot, and changing directions, you just get this type of sensation. And every time your knee gives out like that, you can do more damage in the knee, tear the meniscus, damage the articular cartilage. So surgery rates, or surgery is recommended for pretty much any active people. But then yes, there's aggressive rehab after that. Otherwise, potentially you end up with a stiff knee like what Brittany was talking about. And that's through no fault sometimes of the patient. That can be, yes, really terrible physical therapy, not starting physical therapy early enough, not keeping your knee fully straight. The bigger problem early after ACLs is actually you don't get your knee all the way straight. The mistake people do is they put 2 or 3 pillows under their knee, nothing under their foot, so they lay on the couch with their knee like this, and then it gets really hard to get their knee all the way straight. I'm not a big fan of braces after ACL surgery. That would be the one reason that is potentially helpful, is to lock it out straight, especially when you're sleeping, just to make sure you get full extension, because full extension is really hard to get back if you don't have it by 4 weeks, and it is almost impossible to walk normally if you don't have full extension. But where was I going? The reasons you could get a stiff knee through no fault. I mean, yeah, it could be the patient not working on it. Could be excruciating pain that makes range of motion hard, which that's a little unusual. Poor physical therapy, starting too late. Yeah, those are and I guess some people can be genetically predisposed to that. Sometimes it happens, 3 to 5% of ACL reconstructions get a stiff knee after surgery. But so I suppose it does happen occasionally despite all your efforts, but it's typically what can I do to prevent my knee from getting stiff? Because the treatment of it once it happens, not as nearly as successful as preventing it generally. All right, Robert, it's good to see you. I haven't seen you in a while. I wondered if you are not able to watch our Better Than Ever live shows on at 5 now. I moved them back to 5 because my practice, I switched practices this past summer, and so I was kind of slow ramping up. But now I'm busy enough that noon is just very unpredictable whether or not I'm going to make it back to my home TV studio. So Jamie says, oh, you're very welcome. I am happy to answer your question. Scared because you never had surgery. Yeah, it really depends if it healed appropriately. And clavicle fractures, as long as I can't make this break. Well, I could, but I'm not going to. This was too expensive. But here, I'll show you with my hands. If there's contact with the fracture, even a little bit, if there's a little bit of step off, that's going to heal fine. If it lines up perfectly, it's going to heal fine. A little bit of step off, as long as there's contact. What will not heal well is if the ends of the bones don't touch. In the past, we treated all collarbone fractures without surgery, and then wondered why people didn't have good motion, didn't have good strength, and continued to have pain. But assuming that there was some contact there, typically that heals. Doesn't mean it won't leave a big wad of bone that you can see and feel, but most people that's not painful. Chesta, you absolutely can. Rainier, ACL reconstruction this Sunday. You are so welcome. Good luck with that. Did that right? No, not this Sunday. I'm curious what country you're in. You'd be hard pressed to find a surgeon operating on Sundays here in the United States. It'd be cool if you could, because then you wouldn't have anybody else operating, but I can't imagine it would be fun to try to convince the anesthesiologist and the nurses and the nurse anesthetists to work on a Sunday. Maybe I'm wrong. What else? Chesta, if you've got a question, definitely ask. Otherwise, I am taking off. Let me see. PCL avulsion. Yeah, so we've talked about most of that. All right. While I'm waiting to see if Chesta asks a question real quick, Joy, I didn't see your question. Make sure it's in the chat, because I have no way to see the comments. I'm not on YouTube. I'm using a service called Restream. That's what allows me to send it to Facebook and LinkedIn on Tuesdays and Thursdays. If you do want to see me as a patient, if you want to enjoy bright blue skies, no clouds, and 66 degrees, and as soon as you make an appointment, I know that'll be the day that it rains in the afternoon, but you're welcome to come see me in Charleston, double board certified, hopefully by early this fall. Triple board certified, also not just orthopedic surgery, orthopedic sports medicine, but hopefully soon anti-aging and regenerative medicine. I would love to see you. I cannot really do telehealth where then we send you medications or treatments because I don't have a license in the other 48 states. But go to my website. There's a link below this in the description below. Takes you to my website. There's a work with me box in the upper right corner of that homepage. It drops down. You click on contact. You fill out the form, and you can request an appointment. I talk about things, not just surgery, not just cortisone shots, not just physical therapy, that have become the only 3 things that orthopedic surgeons seem capable today of suggesting to people, with some rare exceptions. And we talk about all kinds of things for what that's worth. Where am I missing? I am not seeing it, Joy, in the chat. I'm really not. Chest, wrist bone dislocated. Can you do it? Depends on which bone was dislocated. In the wrist, that's really unusual. The one that typically happens, and again, this is uncommon, but it can, is a scapholunate dislocation. Scaphoid is under the thumb, the lunate is the one next to it, and you can get a scapholunate dislocation in either direction. That almost always needs surgery because, one, it's hard to pop back into place just closed, possible but not easy, but then it's very unstable and would lead to arthritis really quickly, so that typically needs to be fixed. If that's, again, what it is, I don't know in your case, but if that surgery goes well, and if I remember, that's the surgery that Bradley Beal had with the Washington Wizards this year. I assume he had surgery for it. And so, yeah, you get back to sports pretty well from that. Rainier says he's from the Philippines, but he's in Qatar to do the ACL surgery. Oh, and you can watch the World Cup draw in a little bit. That's actually in Qatar, right, going on really soon, I think, to find out who plays who and who's in what groups in the upcoming World Cup. Good luck on surgery. I really hope that goes well. And Joy, I am not seeing your question in the chat, and I apologize if there's, if you want to retype it, I will be happy to answer. Grandpa says, glad to be here, do things anti-aging. I love this stuff. So people ask sometimes, and I haven't completely pivoted. I still do orthopedics and sports injuries and ankle sprains and hamstring strains. I just have access to things I didn't have in traditional orthopedic surgery. And I did it because the practice I joined, I was a patient of for 3 or 4 years before I switched, and I kind of always wanted to try some of these treatments on other people that I was able to try myself, and just decided I would be one of the 2 or 3 orthopedic surgeons in this country that does it. So for what that's worth. You are so welcome. There's Joy's question. 8 months out from total knee, released at 4 months, feeling a catch with every step. I'm not sure, Joy, the catch you're feeling, but it's not uncommon. There's 2 things I could think. There is an asymptomatic, or not asymptomatic, there's a bad thing going on, click, that a lot of people have. It's just with knee range of motion. This is not, I don't have the metal and plastic in this, but as your knee goes through a range of motion, sometimes the plastic and the metal create just a little click. Most people are like, that's kind of interesting, but they don't think anything of it. But what can happen, assuming if you had metal here, plastic tray, and then the plastic component underneath the kneecap, sometimes you can develop scar tissue. It's typically, which side is this? Sort of toward the upper and outer part of the kneecap. You develop a little bit of scar tissue, and then as you go through a range of motion, it clunks. It's like a noticeable, not just a little click, but like a clunking sensation every time you do it. That sometimes needs surgery to go in and scope the knee and just clean out the scar tissue. Early in my career, I did a lot of those scopes for joint surgeons that didn't do arthroscopic surgery and the rare patients they had with patellar clunk syndrome. Those are typically the 2 things that it is, usually a catching sensation, something like that. Or I guess it could be just buildup of scar tissue, but I would think that that would have manifested even earlier. You would have noticed it. I hope that, it's hard to say. That's one of those things that the joint surgeon, or at least you could feel the knee and figure out where the catching is coming from. It's kind of hard short of that. But yeah, check with your orthopedic surgeon and see what he or she thinks the cause is. Most of the time, not a big deal, but the patellar clunk would be something that sometimes you could go in and scope the knee and clean that out. All right, very excited to be here. I'm going to wrap it up. I'm hitting the gym. I have a rare Friday afternoon off, and so I'm going to enjoy it, and I'm going to lift weights and do some sort of cardio and be right back here. I will be here Tuesday, 5 p.m. Eastern Time for Better Than Ever Live, where we're going to talk about, I can't remember what we're talking about. We're either talking about whole body vibration therapy like I was talking about earlier. I can't remember what it is. I apologize. I'll put it in YouTube if it's not already in there. I will not be here Thursday, and I will not be here Friday. I'm doing something really cool on Friday that will cause me to miss it. So no Ask Dr. Geier Friday next week. If those of you having surgery or things, keep me informed. Come back on Fridays and let me know how things are going. We can follow your progression, and I can answer questions about how it goes, including those who, was it Rainier that said he was having surgery on Sunday? Good luck with that. But I hope it goes well. But very, very thankful for you guys being here and you ladies being here. Very much appreciate it. Look forward to seeing you on Tuesday. Have a fantastic weekend.